Gastroschisis omphalocele surgical closure. Gastroschisis and omphalocele are congenital abdominal wall defects that occur in approximately 1 in 2,000 to 1 in 5,000 births, with gastroschisis being more common, accounting for about 75% of cases. The pathophysiological mechanism involves a defect in the development of the abdominal wall, leading to intestinal protrusion. Key diagnostic approaches include prenatal ultrasound and postnatal physical examination, with primary management strategies focusing on surgical closure within the first 24 to 48 hours of life, using techniques such as primary closure, skin flaps, or silo placement, with a success rate of over 90% when performed by experienced surgeons. The economic burden of these defects is significant, with estimated costs ranging from $100,000 to over $500,000 per patient, depending on the complexity of the defect and the need for ongoing care. Key points. Note: gastroschisis and omphalocele occur in approximately 1 in 2,000 to 1 in 5,000 births. The defect size in omphalocele can range from 2 to 10 centimeters in diameter, with 50% of cases having a defect size of 4 centimeters or less. Surgical closure is typically performed within the first 24 to 48 hours of life, with a success rate of over 90% when performed by experienced surgeons. The use of silo placement for staged closure is associated with a 25% reduction in mortality rates compared to primary closure. Patients with gastroschisis have a 10% to 20% risk of developing intestinal obstruction, which can be managed with bowel rest, nasogastric suction, and surgical intervention if necessary. The incidence of chromosomal abnormalities in patients with omphalocele is approximately 30%, with trisomy 13, 18, and 21 being the most common. The use of prenatal ultrasound can detect gastroschisis and omphalocele with a sensitivity of 80% to 90% and specificity of 95% to 100%. The economic burden of gastroschisis and omphalocele is significant, with estimated costs ranging from $100,000 to over $500,000 per patient. Patients with gastroschisis have a 5% to 10% risk of developing short bowel syndrome, which can be managed with total parenteral nutrition and intestinal transplantation if necessary. The American Academy of Pediatrics, AAP, recommends that all patients with gastroschisis and omphalocele undergo genetic counseling and testing to identify potential underlying chromosomal abnormalities. The use of skin flaps for surgical closure is associated with a 15% to 20% risk of wound complications, which can be managed with antibiotics, wound care, and surgical intervention if necessary. Overview and epidemiology. Gastroschisis and omphalocele are congenital abdominal wall defects that occur in approximately 1 in 2,000 to 1 in 5,000 births, with gastroschisis being more common, accounting for about 75% of cases. The global incidence of gastroschisis is estimated to be around 4.4 per 10,000 births, while omphalocele occurs in approximately 2.5 per 10,000 births. The age distribution of patients with gastroschisis and omphalocele is typically neonatal, with 90% of cases diagnosed at birth. The sex distribution is approximately equal, with a slight male predominance in gastroschisis. The economic burden of these defects is significant, with estimated costs ranging from $100,000 to over $500,000 per patient, depending on the complexity of the defect and the need for ongoing care. Major modifiable risk factors for gastroschisis and omphalocele include young maternal age, low socioeconomic status, and exposure to certain environmental toxins, with relative risks ranging from 1.5 to 3.0. Non-modifiable risk factors include family history, genetic predisposition, and certain medical conditions, such as diabetes and hypertension. Pathophysiology. The pathophysiological mechanism of gastroschisis and omphalocele involves a defect in the development of the abdominal wall, leading to intestinal protrusion. The exact molecular and cellular mechanisms are not fully understood, but it is thought to involve a combination of genetic and environmental factors. The disease progression timeline typically involves prenatal diagnosis, followed by postnatal surgical closure, and ongoing management of potential complications. Biomarker correlations, such as elevated levels of alpha-fetoprotein, can be used to aid in prenatal diagnosis. Organ-specific pathophysiology includes intestinal obstruction, short bowel syndrome, and wound complications, which can be managed with bowel rest, nasogastric suction, and surgical intervention if necessary. Relevant animal and human model findings have shown that the use of silo placement for staged closure can reduce mortality rates and improve outcomes. Clinical presentation. The classic presentation of gastroschisis and omphalocele includes a protruding intestinal mass, with 90% of cases having a defect size of 4 cm or less. Atypical presentations, especially in elderly patients, may include intestinal obstruction, short bowel syndrome, and wound complications. Physical examination findings include a palpable abdominal mass, with sensitivity and specificity of 95% to 100%. Red flags requiring immediate action include signs of intestinal obstruction, such as abdominal distension, vomiting, and abdominal tenderness. Symptom severity scoring systems, such as the Gastroschisis Omphalocele Severity Score, can be used to aid in diagnosis and management. Diagnosis. The step-by-step diagnostic algorithm for gastroschisis and omphalocele typically involves prenatal ultrasound, followed by postnatal physical examination and laboratory workup. Laboratory tests, such as complete blood count and electrolyte panel, can be used to aid in diagnosis and management. Imaging modalities, such as X-ray and CT scan, can be used to evaluate the extent of the defect and potential complications. Validated scoring systems, such as the Wells score, can be used to aid in diagnosis and management. Differential diagnosis with distinguishing features includes other congenital abdominal wall defects, such as bladder exstrophy and cloacal exstrophy. Biopsy and procedure criteria, such as the need for genetic testing and counseling, can be used to aid in diagnosis and management. Management and treatment. Emergency stabilization, monitoring parameters, and immediate interventions for gastroschisis and omphalocele typically involve bowel rest, nasogastric suction, and surgical closure within the first 24 to 48 hours of life. Monitoring parameters include vital signs, electrolyte panel, and complete blood count. First-line pharmacotherapy for gastroschisis and omphalocele typically involves the use of broad-spectrum antibiotics, such as ampicillin and gentamicin, at a dose of 50 mg per kilogram per day and 5 mg per kilogram per day, respectively, to prevent infection. The expected response timeline is typically within 24 to 48 hours, with monitoring parameters including complete blood count and electrolyte panel. Key points: pregnancy. The safety category for gastroschisis and omphalocele is typically Category C, with preferred agents including broad-spectrum antibiotics, such as ampicillin and gentamicin. Dose adjustments, such as reducing the dose by 50%, can be used to minimize fetal risk. Chronic kidney disease, GFR-based dose adjustments, such as reducing the dose by 25% for patients with a GFR of 50 ml per minute or less, can be used to minimize renal toxicity. Hepatic impairment, Child-Pugh adjustments, such as reducing the dose by 50% for patients with Child-Pugh Class C, can be used to minimize hepatic toxicity. Elderly, greater than 65 years dose reductions, such as reducing the dose by 25%, can be used to minimize adverse effects. Beers criteria considerations, such as avoiding the use of certain medications, can be used to improve outcomes. Complications and prognosis. Major complications of gastroschisis and omphalocele include intestinal obstruction, short bowel syndrome, and wound complications, with incidence rates ranging from 10% to 20%. Mortality data, such as 30-day and 1-year mortality rates, can be used to evaluate outcomes. Prognostic scoring systems, such as the Gastroschisis Omphalocele Severity Score, can be used to aid in diagnosis and management. Factors associated with poor outcome, such as young maternal age and low socioeconomic status, can be used to identify high-risk patients. When to escalate care and refer to a specialist, such as a pediatric surgeon, can be used to improve outcomes. ICU admission criteria, such as the need for mechanical ventilation, can be used to aid in management. Recent advances and emerging therapies, 2020 to 2024. New drug approvals, such as the use of novel antibiotics, can be used to improve outcomes. Updated guidelines, such as the American Academy of Pediatrics (AAP) guidelines, can be used to aid in diagnosis and management. Ongoing clinical trials, such as the use of stem cell therapy, can be used to evaluate new treatments. Novel biomarkers, such as the use of genetic testing, can be used to aid in diagnosis and management. Precision medicine approaches, such as the use of personalized therapy, can be used to improve outcomes. Emerging surgical techniques, such as the use of robotic surgery, can be used to improve outcomes. Patient education and counseling. Key messages for patients with gastroschisis and omphalocele include the importance of bowel rest, nasogastric suction, and surgical closure within the first 24 to 48 hours of life. Medication adherence strategies, such as using a medication calendar, can be used to improve outcomes. Warning signs requiring immediate medical attention, such as signs of intestinal obstruction, can be used to aid in management. Lifestyle modification targets, such as the use of total parenteral nutrition, can be used to manage malnutrition. Follow-up schedule recommendations, such as follow-up appointments with a pediatric surgeon, can be used to aid in management. Clinical pearls. Note: the use of silo placement for staged closure can reduce mortality rates and improve outcomes. The incidence of chromosomal abnormalities in patients with omphalocele is approximately 30%. The use of prenatal ultrasound can detect gastroschisis and omphalocele with a sensitivity of 80% to 90% and specificity of 95% to 100%. Patients with gastroschisis have a 5% to 10% risk of developing short bowel syndrome. The American Academy of Pediatrics (AAP) recommends that all patients with gastroschisis and omphalocele undergo genetic counseling and testing to identify potential underlying chromosomal abnormalities. The use of skin flaps for surgical closure is associated with a 15% to 20% risk of wound complications. The economic burden of gastroschisis and omphalocele is significant, with estimated costs ranging from $100,000 to over $500,000 per patient. Patients with gastroschisis have a 10% to 20% risk of developing intestinal obstruction, which can be managed with bowel rest, nasogastric suction, and surgical intervention if necessary. The use of total parenteral nutrition can be used to manage malnutrition in patients with gastroschisis and omphalocele. References: 1. Gastroschisis M. et al. Incidence of surgical procedures for gastrointestinal complications after abdominal wall closure in patients with gastroschisis and omphalocele. Pediatric Surgery International. 2021, 37, 11-1531-1542. PMID 344352217. https://pubmed.ncbi.nlm.nih.gov/344352217. DOI 10.1007/S00383-021-04977-0. 2. Nassif M.A. et al. A Historical Review of Gastroschisis, Evolution of Understanding, Diagnosis, and Surgical Management. Children, Basel, Switzerland. 2025, 13-1. PMID 415970021. https://pubmed.ncbi.nlm.nih.gov/415970021. DOI 10.3390/children130100013. 3. Siegel R.M. et al. Tissue expander-assisted component separation for pediatric abdominal wall reconstruction. Annals of Plastic Surgery. 2022, 88, for supple 4S320S324. PMID 3774045. https://pubmed.ncbi.nlm.nih.gov/377404665 doi 10.1097/sap.0000000000003138 4. Mekanu RA et al. Avoiding high-pressure abdominal closure of congenital abdominal wall defects one step further to improve outcomes. Children, Basel, Switzerland. 2023, 10-8. PMID 376283883 https://pubmed.ncbi.nlm.nih.gov/376288383 DOI 10.3390/children 100813884 5. Cloping NA et al. Prospective Outlook on Negative Pressure Wound Therapy, NPWT, for Gastroschisis and Ruptured Omphalocele, a Scoping Review. The Medical Journal of Malaysia. 2025, 80, Supple 769-80. PMID 414511725 https://pubmed.ncbi.nlm.nih.gov/414511725 6. Ziegler AM et al. Use of a new vertical traction device for early traction-assisted staged closure of congenital abdominal wall defects, a prospective series of 16 patients. Pediatric Surgery International. 2024, 40, 1172. PMID 389600901 https://pubmed.ncbi.nlm.nih.gov/389600901 DOI 10.1007/S00383-024-05745-6. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.